Okay. So this is the first case. Right. So this is 19-year-old female patient presented to emergency department with headache and confusion. Hemoglobin is 97. MCV is 61. White cell count is 132. And platelet count is 61. If you can please allow the people waiting in the lobby, I will be thankful to you. So this is the 19-year-old patient with 98 hemoglobin, 67 MCV, white cell count 132, and platelet count of 60. Do we have any biomedical scientists in our session? If there is any, shout out. Any biomedical scientist? No. No. So, for example, I'm the biomedical scientist. I have seen this blood film, very high white cell count, and I have seen this few large cells, and some of them are small, looks mature as well. To me, there is an RBC, right? And I am the first year BMS, for example. I am a trainee BMS. I have seen these few NRBC as well, and I think that this is a CLL. Okay, because I'm a first year trainee BMS, I haven't seen blood film before, so I think that this is CLL. So I have referred this case to clinical hematologist. So now I need a clinical hematologist to comment on this blood film. This is power 50.
Dr. Amir, can I go ahead?
Yes. Please report the blood film.
Yeah. So this is leukoerythroblastic blood film showing very high white cell count, and the white cells consist of largely monomorphic population, which are large in size with abundant cytoplasm. Um, some have prominent nuclei. So some cells are also showing cytoplasmic vacuoles. Uh, Platelet count is reduced, and MCV is also, as you already said, that it is a low MCV, so most likely hypochromic microcytic red cells. And overall, the picture is concerning for uh, acute leukemia and most likely belonging to the monocytic lineage, maybe acute monoblastic leukemia.
Okay. So as I mentioned to you, I am a first year trainee BMS. So I would be asking you, why do you think that this is acute leukemia, not CLL? What 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 difference is there in the blood film to you that suggesting to you that this is leukemia, acute leukemia, not chronic leukemia? How would you tell me?
Uh, so firstly, the cells don't look like the CLL cells. They don't look like mature, small mature lymphocytes. They are big in size. I can't see much of, so although there are some smear cells, but not huge. So they are not lymphocytes basically. They look monocytic. And platelet count is reduced. The other thing that goes more in favor of acute leukemia, the age.
Okay, good. age also goes in favor of acute leukemia as well.
Yeah.
Right. So now
And
you're
the cell morphology, most of them are because they have abundant cytoplasm. The cytoplasm has vacuoles. The nucleus is also kidney bean shaped. So they are more in keeping with the monocytic lineage than the lymphoid.
okay, all right, all right. So now you think that this is acute leukemia. What next step you would like to do? Your report does not finish at
Mhm. Yeah.
just about acute leukemia. You need to tell something else as well.
Yeah. So I will inform the consultant who is looking after the lab on that day, and I'll send the report, the blood film, the blood sample immediately for uh, immunophenotyping, and I'll call the patient where the patient is at the moment. If it is a GP film, we can actually call the patient immediately to hospital, and then we can admit the patient, do bone marrow, send urgent
The patient is
cytogenetic.
in the hospital because he
Is in
presented
hospital.
with headache and slight
Yeah,
confusion.
yeah. So,
You would say that
if yeah. So if the patient is coming with headache and confusion, then with such a high white cell count, there is a risk of leukostasis, and so we would like to. I don't know if we can do. I'm sorry.
okay, so this patient, you think that this is acute leukemia. Most likely, uh, this is, as suggested from this picture, even in presence of you as well, and you mentioned as well. This patient needs admission under hematology, blood flow, peripheral flow cytometry, imaging of the head for any uh, ischemic event or hemorrhagic stroke, and urgent bone marrow biopsy. Okay. This patient count is very high. You need to reduce the counts by hydroxychloroquine. Okay, and if the CT scan shows uh, any findings, if it is ischemic stroke, you need to enroll neurology. If it is hemorrhagic stroke, you need to enroll neurosurgeon. High white cell count, acute leukemia, and headache. Usually, they have something in the head, either a stroke or hemorrhage. Most of the time, it is hemorrhage. And she's 19-year-old, so you need to enroll the neurosurgeon if there is a peak. So I could see there was someone, Farhan Khalid. Your hand was up.
Yeah, so basically, pretty much echoing Romana's thing that this patient does have predominantly monomorphic appearance of the cells, favoring more blastoid, more blast-like picture rather than anything else. And I don't think it's CLL simply because they are not CLL cells are more small and mature. These don't look mature at all. They do look very large, and there are some kidney shaped among them. Yes, acute leukemia would be a diagnosis in this one. One of the things, and it depends to center. I think if the white blood cell count is more than 100, you can technically send cytogenetics from the peripheral blood itself, but it's very specific, so not all centers do that. You can also send you can send for flow and cytogenetics from the peripheral blood if the white blood cell count is more than 100. And obviously, but if that's not the case, do an urgent bone marrow, and as everything what you said, Amir.
Oh, thank you. Right. So we are suspecting that this is myeloid category of leukemia. So
Yeah.
again, the same question. According to BSH 2022, what gene panel or myeloid panel you would like to send to for this patient? What you would like to check in the
So
cytogenetics?
So this will first you will start with your flow. Your flow will guide where it is. Obviously, although it is very likely to be myeloid, but you can be proven wrong. So you start with your flow, and then you send your myeloid gene panel. I mean, looking at it, I would send the myeloid panel on its own, the entirety. So in NHMD at least you can send the entire myeloid panel in one go, which includes pretty much all of the cytogenetics.
What cytogenetics? The BSH has mentioned four categories
S-
that is
Uh,
usually asked in the exam as well. Like what's minimum genetic test you would like to send for a new acute myeloid leukemia?
that's a good question. No, no, I don't know the answer to that. I think probably, if I'm guessing now, it would be 821, inversion 16, NPM1, flat threes, BC, translocation 922, 816. Yeah, I'm guessing now. Sorry, this one I'm guessing now. I'm guessing.
First category is karyotyping. Second category is FISH/PCR for 821 inversion 16 and KMT2A. FLT3 NPM1 is a third category, and the whole genome sequencing is a fourth category. If there is a blood film
Okay.
of acute myeloid leukemia in the exam, this question will be there marks for 2 marks.
Sorry, Dr. Amir, can you kindly repeat?
Um, it will be karyotyping number one, number two, FLT3 with NPM1,
Yeah.
number three is the inversion 16, 821, and KMT2A, and then the fourth one is whole genome sequencing for the mutation, the
Okay.
NGS panel.
Thank you.
Thanks, Sam.
There is a table given in the BSS chart, and but this question is must ask if there is a any type of AML given in the. What treatment option do you have for this patient?
You want me to try?
Yeah, anyone?
Yeah. So assuming that this is acute myeloid leukemia, so first we will need to do we need to know its cytogenetic. First, like right now, the bigger picture is the bigger picture, and the patient is confused. We need to know why. So, does this patient have any evidence of hyperleukostasis? Do we need to do leukophoresis? These are the second question. Or hydroxycarbamide can reduce the count if there's nothing else going on. And neurology, as we said, now based on the cytogenetics, we make a decision on what to do next. So our options of treatments include either trying, if it is high risk cytogenetics, we can even consider going flag ida plus. If there is flat 3, we can add midostaurin. If that's not the case, we can consider local protocol depending on the depending on the trust. You can consider, if they're standard risk cytogenetics, you can consider giving cytarabine plus daunorubicin plus go, if your trust guideline allows, or otherwise if clinical trial, then go for clinical trial. But actually, first you should mention clinical trial, then everything else. I should rephrase.
Mm. So yes, cytoreduction is must, but if there is any intracranial event, then leukophoresis. We have two intensive treatment, which is DA and the Flagida. If it is a standard risk AML, then it is DA. But if there is any other genetic mutations involved, then Flagida. So this case, by by morphology, it is acute um, monocytic leukemia, but we know that we now follow the genetic mutations as per the WHO 2022. This patient had no genetic mutations. Um, so we treated this patient with DA and then followed by transplant as per MDT decision. Although in standard risk AML we do not do transplant, but she was very young. We did allograft. She is in remission now.
Dr. Amir, I just have a question. S- Uh, I have heard that we can do the leuko reduction with the cytarabine as well. Is that also something to consider, or it's only
Dovanorubicin,
hydroxyzine?
Dovanorubicin is used sometimes.
Daunorubicin.
Yeah.
Okay.
But if there is any intracranial event, then we have leukapheresis machines. We leukapherese them, and then the counts come down to double figure very, very quickly. Or high doses of hydroxycarbamide, but you may not use it in all patients because they may have cytopenias, and there is contraindication for that. So either leukapheresis or um, cytoreduction with hydroxyurea or daunorubicin. Yes, sir. This is another 40-year-old patient admitted with fever and productive cough. He is on oxygen as well, supplemental oxygen. His white cell count is also 132, and um, hemoglobin is 108, and platelet count is 98. This is the blood film, power 10. Let's see if we can figure out difference between this one and the previous one.
It has neutrophils and lymphocytes. It has all
But
kinds of cells.
if there is a biomedical scientist, will be happy if a
Hmm,
biomedical scientist comment on this first, because the blood film goes to biomedical scientist first.
true.
Anyone from lab? No one from the lab?
I can try.
Yes, go on. What do you think?
Okay. First of all, the peripheral smear showed uh, leukocytosis with left shift and mostly neutrophilia, but these are dysplastic with hyposegmentation as well as hypogranularity. And I haven't seen any blast here yet. And yeah, this may be this is looking like a immature cell here on 1 o'clock. And RBCs, there are several nucleated red cells along with anisocytosis with spherocytes and rhomocytic, normochromic, and macrocytes as well. And platelet are reduced in the field. Orality, these are reduced. There is thrombocytopenia. So based on uh, history and smear findings and counts, my suspicion is mm, this can be uh, this can be the clonal or this can be the reactive. So I give a DD differential here for infection. This can be secondary to the infection or this can be secondary to the clonal cause, MPN, most likely CMML. So advice for further investigation like flow cytometry and infection serology,
You mentioned
imaging.
you are from lab. You will refer it to clinical hematologist, right?
Okay, so I will refer. I don't know whether he was male or female. I will refer her to the clinical hematologist.
Okay, all right. So now we request the clinical hematologist to report the blood film because she, as a lab person, thinks that this is either reactive or CMML. So you need to report it and tell her whether this is reactive, CMML, or something else. Because as a clinical hematologist, you teach your lab people as well.
Dr. Amir, can I go ahead?
Yes.
So the blood film shows leukocytosis, uh, and the leukocytes. It is a leukoerythroblastic blood picture with the leukocytosis showing dysplastic neutrophils with left shift, and then there are some occasional blasts as well, along with dysplastic monocytes. Red cells also show dysplastic changes. There is anisopoikilocytosis with some teardrops, spherocytes. There are quite a lot of stomatocytes as well. Platelets are reduced, and given the history, I think the overall findings are suggestive of CMML based on the dysplasia as well. Uh, and since the patient has a history of some infection, we should also check for infection markers. But the blood film findings overall are suggestive of MDS, and most likely CMML.
Why CMML?
Why CMML?
Mhm.
Because there is a dysplasia. I can't see any striking basophilia to call it CML.
Okay. And where is the monocytes? Have you seen monocytes or promonocytes?
Not really.
Then how can you call it as CMML?
Yeah, I haven't seen much, but it is quite dysplastic, and but I can't call it a CML. So sure.
Okay, all right. So Asma Nasir has hands up. Uh, do you want to add anything, Asma Nasir?
Yes, sir. I was just thinking that there is leukocytosis with dysplasia and blast cells, but we cannot see increase in monocytic cells like dysplastic monocytes or abnormal monocytes. I cannot appreciate it, and there is absence of basophilia. Can it be atypical CML?
Okay. You think this is atypical CML? Farhan has a
Mm,
well,
yeah,
I,
may I
I
ask one thing? Is it sorry? I may you decide who speaks first.
yes, go on, Farhan. And then we have done.
Is this the first only time that the cells accounts are increased, or because you said the patient came in with an infection? So is this the first time the white cells have jumped all of the sudden? That's the first question I have. Is there any previous bloods to compare? Second question. Third question is these look quite reactive to me, although they are, I agree, they are dysplastic cells everywhere in the periphery. I can see dysplastic cells. There is anemia, but I would say it's a leukoerythroblastic picture with neutrophilia and or left shifted with dysplastic features as well. So yeah, it is suspicious of a hematological disorder, but I wouldn't call it CMML.
Yeah. So first of all, in the exam, they will not give you such information. How was
True.
the patient was previously. They have given you a story that the patient has a high grade fever, chest symptoms requiring oxygen. This is the count 132, and this is the blood film. Some people are sending messages in the Teams. I cannot read the messages. Please speak up. What do you have, Danish?
Well,
Do you have any different ideas?
hi, Amit. I think it's definitely not CMML, sorry. So this is a leukoerythroblastic film. Based on the history, I would say that this is likely a reactive picture, or I don't know if obviously in exam setting it's difficult to compare, as you say. So I would just say if persistent and my underlying diagnosis, well, it could. Why can't it could be MDS as well? If obviously if the history is currently is an infection, but why can't it be MDS?
MDS with white cell count of 32 or 132.
Oh yeah, sorry, I
It is
missed the counts. Yeah,
the
sorry, maybe
count
I'm a
pretty
bit half
high.
asleep. Yeah, counts are very high. Sorry, I was a bit half sleepy. So yeah, counts are very high. Yeah.
So it's not CML because there is no basophilia. It's not CMML because there is no promonocytes and monocytes.
Leukomoid reaction.
Hmm. So many
It's
of
the
you said
Leukoerythroid
that
reaction.
this is leukoerythroblastic picture, and I am first year BMS trainee. This is my first day in the lab. I'm asking you what is a leukoerythroblastic picture? So what would you say?
Presence of dysplastic features including nucleated red blood cells or presence of blast, but not a very high count of blast can indicate that this patient has a leukoerythroblastic feature.
Dr. Amir, I think
NRBC,
it is the left shifted myelopoiesis as well as the presence of nucleated red cells, which we can call leukoerythroblastic blood picture.
NRBC plus myelocyte plus
Yeah.
dysplastic neutrophil.
Yeah.
Hilal al Musta has hand up. Hilal, you can speak. Okay. So first of all, the history. This patient is admitted with infection. Okay. He has severe chest infection, which is requiring oxygen. Right? There is no basophilia in this patient. Okay. And no monocyte per monocyte. There are a lot of NRBC and myelocytes, neutrophilia, dysplastic neutrophilia. Okay. Um, all this picture belongs to sepsis, acute sepsis, and severe sepsis. Okay. So that's how you can be tricked in the exam. Some of the people will say this is CML, CML because the counts are very high, but there is absence of basophilia. Some say that this is CMML too, but there is no promonocytes or monocyte. This patient has, the history tell you that this patient has severe infection. In CMML or in CML, the patient is normal. They do not have any infection. They would have tell you that this patient has abdominal discomfort, which means there is splenomegaly. If there is CMML2 or if there is CML, they will tell this patient has abdominal discomfort. They will not tell you that this patient has big spleen. They say abdominal discomfort.
Dr. Amir, but what about the dysplasia? Can the infection also explain the dysplasia?
Yes, infection can lead to NRBC. Your bone marrow is under stress. It can
No,
lead
NRBC is
to
okay, but the neutrophils are dysplastic. I mean, in the infection, we mostly see neutrophils with the toxic granulation, and the picture is entirely different. These are dysplastic neutrophils,
when
hypolucrated.
the bone marrow is under stress, you get a dysplastic picture. You say that
Uh,
this is a leukoerythroblastic picture. So one of the cause of leukoerythroblastosis is sepsis. Bone marrow under stress can lead to leukoerythroblastic picture.
Dr.
Dr. Ahmed,
Amir,
I
sorry.
agree with you with the LEB picture can give the dysplastic feature. My question is that the background RBC, many of the RBCs are like stomatocytes. And my second question, can we give differential diagnosis in that case if we are not confirmed about the leukomite reaction, whether or any clonal cause?
Which clonal cause? Again, this is you are raising the same question. Which clonal cause?
No, I'm not saying any specific clonal cause. I'm saying about the MPNs. So
Which MPN? MPN is a big category.
CMML, but
But
you
there
are
is no
right.
monocyte. There is
No,
no pro-monocyte.
no,
Why
no.
are you
Yeah,
calling it as CMML?
okay. Okay. Atypical CML can be considered here, but uh, mature components is also more than 10% here. Immature component should be less than 10%. So it is not fulfilling the atypical CML as well.
There is no more
May I,
atypical
Amit?
CML after the WHO 2022. You can say MDS MPN with neutrophilia.
Okay.
Uh, but this patient history is clear. This patient has severe infection. If there are stomatocytes, it's because maybe he is heading towards DIC. Liver is involved. When liver is involved, there will be stomatocytes.
Okay.
Yeah, I agree with you. I mean, so because they are neutrophilia predominantly, I don't think we can technically say it's anything else. I mean, the only thing is, which is, if you really think there is something going on, it is like as you mentioned, MDS, MPN, or a chronic neutrophilic leukemia. But that's a rare. In this is not happening in a patient with sepsis. So that's not happening in a patient with sepsis. So yeah, it is sepsis.
Yeah. And this slide can be given to you in another form as well. They can only ask you write the findings in the blood in this blood film. Okay, and you have a lot of findings in this blood film. You have myelocytes, you have metamyelocytes, you have band forms, NRBC, you have neutrophil, dysplastic neutrophil, teardrop cells, hypochromia, um, the stomatocytes, low platelet. You have a lot of findings in this blood film. So this blood film can be given to you in a different form as well, which does come in the exam. We had the same question, and many people after me had the same question. They will give you a blood film, say, write only the findings in the blood film. So 1, 2, 3, 4, 5, 6. Or they may ask you, write 6 findings in this blood film. Right? Now we have same 40-year-old patient, a different person, but he is also 40-year-old. Uh, and you have received the blood film, and his white cell count is also 132.
Where do you find these 132 white blood cells, mate? More of a joke.
This is my specialty, so the people refer it to me. All
I
right.
was being funny.
And when you sit in the FRC path exam, all the scenarios and blood film look the same. Remember this.
I believe you, mate.
So this is again 40-year-old man with a white cell count of 132 and platelet count of 98. Platelet count of 198 and hemoglobin of 110. All right. The blood film goes to biomedical scientists first because they are the one who deal with the blood film first. Do we have any BMS here? So we don't have any biomedical scientist?
Uh, Again, I can try.
Yeah. Okay. Give us your preliminary report And then if you are suspicious of anything, refer it to clinical hematologist. So what do you think about this blood film?
So based on this peripheral blood film is showing leukocytosis, and leukocytosis mainly myeloid in hyperplastic myeloid cells like neutrophilia, uh, and I also I also see blast 1 to 2 blast, and these are granular with all the stages of maturation, and I haven't seen any blast here in this field. And yeah, 1 to 2 cells are suspicious, maybe atypical cells and maybe blast like here in the center. And there are all stages of maturation, and platelet are, can you move another field? Platelet are
Mhm.
adequate. Platelet are adequate. I think there is the basophil. I don't know. I have a suspicious. And NRBCs are there in the background. So yeah, blast is also there. So it can be, yeah, this is a basophil. So the based on these findings, my conclusion is most likely MPN like CML. So I will refer the patient to the clinical hematologist.
Oh, all right. Now we need a report from clinical.
Dr. Amir, eosinophilia is also very prominent.
Yeah,
So what does the clinical hematologist says?
You want me to have a go?
Yes.
Yeah. So, looking at the blood film, it shows all predominantly leukocytosis with metamyelocytes, myelocytes, eosinophilia. I saw only, yeah, basophilia as well, and with blasts as well, but the blast counts are not very increased, at least from what I saw in the pictures. This is suggestive of so that among the red cells, it does look, some of the red cells do look hypochromic. Platelets up here normal. This is favoring a diagnosis. It's favoring a myeloproliferative disorder in a form of CML. Suggest further investigation, center flow cytometry, and BCR-ABL. And obviously, patient needs to be seen in clinic or in if the patient is admitted. I didn't hear the initial presentation, so sorry. So if its patient is in, then needs to review, but suggest flow cytometry and BCR-ABL and subsequent bone marrows.
Flow cytometry. Why flow cytometry?
Mainly BCR-ABL, but yeah, but if I would, I usually write the same way. It's sort of a habit. I shouldn't write it technically. You're right.
If you are suspecting that this is CML, then
Ma-
BCR-ABL
Mainly
should be.
BCR-ABL. Mainly BCR-ABL. It's a sort of a habit. I always write flow cytometry. I shouldn't write it. You're right. You have a point. Yes.
So what's the difference between this film and the previous film?
So the previous film has previous film has neutral the history. I think it would be the main, because I didn't hear the history of this guy. Sorry, I apologize. But the first one was a guy with severe sepsis. There was neutrophilia. There was different types cells. If you notice in these one, these cells are sort of clustered together, which is more seen in hematological disorders such as like as we always used to see in morphology, blast and metamyelocytes sort of clump together in form of groups or chunks, as you can see here in this picture that you've shown. In sepsis, usually they're more scattered out. The other thing is the history is the most key defining element here. In that one, you did see a lot of neutrophilia. In this one, we are seeing a lot of neutrophilia. We're seeing eosinophils, we're seeing basophils. In the previous slide, we didn't see any basophils. We saw pretty much every cell line, but not basophils. And the history was the target thing because they were this that guy was admitted with sepsis. Now, in real in practical world, obviously in the exam is a different situation, but in the practical world, if we had seen a previous a day or two blood count, and if we had seen a right jump, we would say it's leukomoid. But obviously, in the exam purposes, that's not the case. So I think this one more favors a disorder rather than the previous one.
This is
Dr. Amir, can
basophil.
I add? Yeah.
Yes. Who is AM? AM had a
Sir,
hand up.
Mia, Dr. Atika.
Mhm.
So, Dr. Atika.
Go on.
Sir, if we talk specifically about this film, how it is different from the previous one, there's a bimodal peak. We can see there are so many myelocytes with along with the neutrophils. Point number one, which favors the CML, as we can see, there are metamyelocytes, but the peak is there's a bimodal peak. The second thing which can I see is the predominance of the eosinophils, as the previous doctor said, and along with the basophils. And on the in the RBC, I can also see macrocytes due to the increased turnover, cell turnover, and due to secondary folate deficiency. So these are the specific things which favor the CML, and it is different from the previous one.
You mentioned everything, but you forget to mention this basophil.
Basophils also, yes, sir. I said this.
These are
So
the key
eosinophilia and basophils,
things.
they are key features which differentiate from the leukocyte reaction.
Hello, Dr.
Okay.
Hoya.
Yes.
Yeah, this is Mayo. I'm just listening in on my phone from the
Mhm.
ward.
Okay. Right. Okay. Which score would you like to use for prognostication in CML?
It is ELTS.
Yeah.
PLTS.
ELTS is one of the three
Which was
scores
that?
that you need to remember for the exam with its component. What is included in ELTS?
Hmm.
Okay. ELTS, the DLBCL-IPI, and the Hazel-Clever score of Hodgkin lymphoma. These are the three scores that you need to remember for the exam.
Okay.
So, and what are the major root abnormalities in CML?
It is trisomy 8, trisomy 19, isochromosome 17q, and extra Philadelphia chromosome.
Hmm. And if this patient is a high-risk ELTS score, what drug we will offer to this?
We will go with the second generation TKI,
Which one?
melatonin.
Deserted.
Dasatinib.
This
Dasatinib.
The Saturn.
Dasatinib. And what are the contraindication to dasatinib?
Any pulmonary features?
Any cause that can lead
Lung.
to desaturation.
Fusions. Hmm.
Yeah. Pulmonary hypertension, pericardial effusion, pleural effusion.
Hmm.
Sorry, Dr. Amir, why did we choose the dasatinib? Sorry,
Sorry?
just a question. Why did we choose dasatinib over everything else?
It's a second generation, more potent than imatinib.
Okay.
So he is a young patient, and secondly, the important thing is that his ELTS score is high, so he's a high risk patient.
Okay. Thanks.
If your patient has high ELTS score, if your patient is a young female and she wants to get pregnant in the future and you want to bring her quickly in remission, then you can start with second generation TKI. If There is no contraindication. This is 19-year-old boy with headache. Came to A&E, and this is the full blood count. Looking at the full blood count, his count is 600. White cell count is 600. His platelet is 68, and hemoglobin is 110. I need a different biomedical scientist than the previous one. And I need a different clinical hematologist than the previous one to report it. Anyone from the lab, from biomedical scientists? There should be someone. There are 36 people. Okay. If there is none, then let's say I am the biomedical scientist, first year trainee, and first day in the lab, I saw this blood film. I thought this is likely CML. I have referred this to clinical hematologist. So I need a clinical hematologist to report this blood film.
Dr. Amir, can I go ahead?
Have you reported
Okay.
before?
Yeah, I have reported
No, I mean,
before.
have you reported in this session?
Yes, I'm Romana.
I would like to give a chance to another person, if there is any. If you don't mind.
Yes, sir, I will.
Sorry?
I will go. I will. Well, this is seems leukocytosis with monotonous all the population, but I will see the low power.
Okay, this is high power for you.
Hyper. Yeah. So there is the mainly the leukocytosis and with uh, blast, blast cells with the high NC ratio, with scanty cytoplasm and prominent this uh, open chromatin and prominent nucleoli. And it's sorry, initially I have to mention medium large size blast, and you cannot see any granularity, very scanty cytoplasm with the basophilic cytoplasm. And in the background, RBCs are anisopolycytosis, macrocytosis, and platelets are reduced, seems reduced, yes, platelets are reduced. So my findings slightly diagnosis. These findings are suggestive acute leukemia.
Suggestive of what?
Yeah, so acute leukemia.
Okay.
Most likely seems maybe lymphoblast. Just I cannot
Sorry?
say. I need I need a confirmation from chemotherapy, bone marrow study, cytogenetic and fish analysis in this case to categorize whether it is lymphoblast. But it seems is medium to large size, scanty cytoplasm. So could be lymphoblast.
Okay. This is most likely leukemia
Leukemia, yes.
because the cells have a lot of nuclei and the
Yeah,
cytoplasm is clear. So likely acute lymphoblastic leukemia, but you will confirm that on flow
yeah,
cytometry.
yes.
Uh, this patient has a CT scan and there is intracranial hemorrhage. What would you do next?
Yeah. So patient has ALL. So and if it is not diagnosed yet, so first we will, because there is intracranial hemorrhage, we will call the neurology, neuro surgery also, and neurology to be involved, and we will start immediately. And our differential is ALL, so we will start immediately prednisolone or Dexa, 6 to 16 milligram per day for 5 to 7 days, and we will send all the workup, and we will go for the hydration. We can start with a TLS, hemolysis syndrome prophylaxis, respiratory maybe, and then we can start if there is immediate management. If it is in differential ALL, we can start with vincristine, and we will avoid any procedure because if there is a hemorrhage. So intrathecal chemotherapy or other, we can avoid it. And uh, the main thing is we will start initial steroid and initial vincristine for this patient and TLS. And of course, monitoring of all the labs to see the DIC and to
The patient died next day.
right.
Yeah.
Okay.
Why he died next day?
So due to
Because of the
leukostasis,
Leukopharis.
extension of intracranial hemorrhage,
Yeah. Mm-hmm.
because you give her steroids and steroid takes many days to show its effect. So you will
Leukopharesis.
be you will be sued. Okay.
Uh,
And then you will appear in a fibrotic
so should
exam
we
from
go for leukopharesis at this stage?
but
So should we
Indra,
admit the patient and start?
we cannot go for the chemotherapy first in ALL patients. Yeah, leukophoresis. We can go leukophoresis. It's 600 count, right?
Yeah. So you need to do
Yeah.
leukophoresis in this patient because this is emergency situation now.
Skip the WBC
Okay.
count. Yeah.
You
Hmm.
need to involve the neurosurgeons urgently
Hmm.
to do any evacuation or not. You need
Hmm.
to check the von Willebrand antigen in this patient because they are all blast. Okay, the von Willebrand antigen may have attached to these blast, and there is no von Willebrand present in the body. We need to check the fibrinogen in this patient as well, cross fibrinogen. This patient may need cryoprecipitate or von Willebrand concentrate um, as well. These are the urgent action that you need to do in this patient. But the most urgent thing is first should be leukapheresis. Remove this white cell from the patient. Otherwise, his um, intracranial hemorrhage will extend and he may die. Right. So I had made a video recently about the hematological emergencies. Okay, if you had heard that video. Okay. Have you heard that video? If not, you need to hear that video. What are the hematological emergencies? And the title was Failing to Recognize Hematological Emergencies Means Failing the Exam. Okay, it is on this website. All right, so if they give you such scenario that the patient has a high white cell count and the CT scan shows intracranial hemorrhage, you need to reduce the white cell count. Leukapheresis may not be available everywhere practically. It is only present in the tertiary center and those districts, hospitals where they are doing autografting. But your answer should be that this patient ideally needs leukapheresis to reduce the white cell count. If none, then high doses of um, cytoreductive, cytoreduction, or transfer of this patient to tertiary center by blue light. Or this should be your answer. Okay. In hematology, the emergency is not only TTP, APML. These are not the only emergencies. There can be a lot of emergencies. 16 or 17 emergencies are there in the hematology that are present in the video that I posted a week earlier on the website. The last blood film, and then you can go. So this is a 60-year-old male patient with white cell count of 32.
Sorry, what's the age?
Sorry, this blood film is a bit defective. I will remove that. I will put another one. This is power 10. This is a GP blood film. Okay. The patient white cell count is 32. And he is 60 years of age. This is power 50. Any biomedical scientist? Just shout out because we are near the end of the time.
So sorry, what is the age of the patient?
60. Looks like we don't have biomedical scientists now. So, for example, I am the first year biomedical scientist. Somebody told me that if the cytoplasm is clear, it is lymphoid. I think that this is lymphoblastic leukemia. I have referred this to you guys. You are the clinical hematologist and you need to report that. So tell me, what is this? I am first year biomedical scientist. Today is my second day in the hospital. You are the professoriate consultant or senior registrar in the hematology. Please tell me, what is this?
Dr. Amir, can I go ahead?
Okay, go on.
So, this blood film shows uh, leukocytosis, mainly lymphocytes, which appear small and mature, with mature clumped chromatin, alongside many smear cells,
Mm-hmm.
and the red cells mostly are nomochromic, alongside a few spherocytes. I can't see any fragments. The platelet count looks okay to me. Sorry, I didn't actually follow what the platelet count you told. There are
Platelet
some.
count is
There are
152.
okay. So there are some lymphocytes which are bigger in size, but the proportion of those lymphocytes is not much. Mainly, they are small, mature lymphocytes. So the overall picture is concerning for an LPD, most likely CLL, but we need to send a flow cytometry to confirm the diagnosis. And if you told me that it's a GP film, so I think if we are suspecting CLL with this count and the patient is must have been well, that's why I think we need to refer the patient, tell the GP to refer the patient to hematology on a 2-week pathway.
Okay. What is a mature? You mentioned mature lymphocyte. What do you mean by mature?
Uh, Dr. Amir,
I am
small.
I am first year biomedical science. I don't know what is
Yes.
mature lymphocyte. So please tell me, what is mature lymphocyte, doctor?
They are small in size compared to the size of a red cell. They're roughly the size of red cell with a slight rim of cytoplasm, which is clear, and they don't have any prominent nuclei in between. The chromatin is clumped, more bluish.
Okay,
Yeah.
yeah, I got it. And you mentioned some smear cells. What is smear cell?
The smear cells are when you can't see the boundary of the cell, and you can't actually make out if it is a complete cell with nucleus and cytoplasm. You just see some blotches of color, just like we can see in this film as well.
Mm.
Just like the cell is broken during preparation.
It is broken during preparation. It is not present in the patient body.
Yes, I think it is broken during preparation because they are very delicate cells, so they are broken during preparation.
So what flow cytometry you are expecting?
So it would be CD19 positive, 79 B positive, CD20 weak positive, surface immunoglobulin weak positive,
Mm.
CD5 positive, 23 positive.
All right, doctor, you said that the CLL cells are small and mature, and they don't have nucleoli. But I can see one cell here. It has nucleoli. What is this?
So in CLL, we can see actually some cells which are um, pro-lymphocytes. They are larger in size with abundant cytoplasm, but they shouldn't be. I don't know the exact percentage. Otherwise, we call them PLL, but uh, less than 15%, I think, are present in CLL.
Dr. Somebody
Can be
said other
present.
day that BPLL has been eliminated after
Yeah,
WHO 20.
yeah. It is now called splenic lymphomas with prominent nuclei.
Lymphoma
Sir,
leukemia
can
with
I
prominent.
comment on this?
Yes.
Dr. Amir. I think I appreciate the any pro lymphocyte on this film because the size is enlarged as compared to the mature lymphocyte. So I will evaluate the whole film for the percentage of the pro lymphocyte. If it is more than 15%, then according to the WHO 2022, that is the pro lymphocytic progression of CLL. But I need to look over the film to get
If it is more than,
the exact count.
and if it is more
15%.
than, if it is more than 55%, then it will become SLLPN, just like the case that we did on the last session,
Yes.
right? So what treatment you want to give to this patient?
Dr. Amir, it is if it is we will need to check it with the patient. If the patient wants a continuous so firstly we need to do the cytogenetics as well, the TP53 mutation,
Unmutated.
and unmutated or mutated. Oh, it is unmutated. Okay. Um, there are two options. First is the fixed duration regime, which will include VI or VO. Venetoclax, ibrutinib, or venetoclax obinutuzumab, or
Doctor,
there is
somebody
another
tell
option.
me that we do not give treatment to all the CLL patients. Is that true?
Yeah. So it is if the patient fulfills the criteria for treatment, which I don't remember fully at this point in time. There
Yes,
is
you
a
need
watch
to
and wait.
see if there is any indication of CLL treatment or not. If you
Yes,
give, if you write like this in the exam, for sure, they will be happy to see you again in the next
yes,
sitting. So do not give CLL treatment to everyone. There is a
yes.
criteria to give CLL treatment. If they have progressive cytopenias or massive splenomegaly, massive lymphadenopathy, or autoimmune hemolytic anemia not responding to steroids, only then you will treat the CLL patient. Otherwise, most of CLL patients go on watch and wait, right?
Okay.
So this was the last
Sorry,
question.
Dr. Amir,
Yeah,
so this was CLL or
this was
SLL?
CLL.
Yeah.
Yeah, all our sessions are uploaded to this YouTube channel, which is in the message section. And can it just be leukoid reaction? Yes. Platelet transfusion, check VWF. Yes. An ALL patient. What about atypical cells having cytoplasmic blebs? Shaista Nazir, can you please explain your point? What do you want to say? Is Shaista with us? Oh, looks like she's gone. Any question?
Amir, sorry, the last one. There is a lot of cells look very reactive with RBC scalloping, bluish cytoplasm. Look like a feature of EBV infection.
Hmm. Where is that? I close that. First of all, uh, scalloping is not always present in uh, a reactive feature. Right? If you were there in first the first case, which was monoblastic AML, this monoblastic AML patient has a lot of scalloping as well. It does not mean that you will call this patient as reactive. Okay? So this is a misnomer that scalloping means a reactive picture. No, whenever the white cell count is high, you will have scalloping.
That's fine. But
And
because
so this patient, see,
yeah,
this is monoblastic AML. It is scalloping to all the cells nearby. Why? You cannot say that this is a reactive picture. This will be a huge blunder if you call this is a there is red cell scalloping and I should call it as selective. This is also bluish. These are all monocytic cells, bluish. Right. This is the one, and in this cell, in this case, um, okay. So you saw a pro-lymphocyte which was scalloping like this one. But where should I fit these cells? Are these cells present in the reactive picture? No, they're
No,
not. If
no.
you go slightly towards thicker side, you will see the size of these cells become smaller and more compact. So here, if you go to a thicker side, they're more compact and the size becomes smaller as well.
Hmm.
Okay, so yes, reactive cells do scallop, but it depends on the patient,
Hmm.
patient clinical history as well. I cannot call this as
Hmm.
a reactive. There are a lot of smear cells, and the cytoplasm is very mature. Sorry, the nuclear material is very mature. I should be thinking about CNL. And in the first case, yes, they were scalloping to everything, but the count is 132. Patient has symptoms, and they are all monoblastic cells. Yes, if there is a 19-year-old patient with few such cells, the reactive cells are usually large with different shapes, with bluish cytoplasm, then I can think that it may be reactive. But in presence of such a large number of smear cells with such a large number of cells which have compact cytoplasm, it is more than reactive.
great. Thank you.
So when you sit
Thank
in
you,
the
Dr. Amir.
exam,
Thank you so
the
much.
scenario usually matters because scenario guide you toward different um, different diagnosis. Right, so this was the end of our session today, and enjoy the hot